Hello, class. This is Module 4, Objective 3, and it's going to be a short one. Yay! Without further ado, let me share my screen and get that guy started. Okay, well, in Objective 3, we're going to identify effective treatment and treatment challenges in the case of dual diagnosis. Now, you remember dual diagnosis is when somebody has a substance use disorder and another mental illness. Okay, well, it's a challenge to treatment. I'm going to talk a little bit about treating adolescents and then treating adults separately. One of the advantages of treating adolescents is that there's less dropout. Part of it is because there are other controls on their behavior. They can't just decide to leave treatment as easily because the parents may be making decisions for them and things like that. So, I mean, it's a little bit better. If in terms of just substance use, just treating the substance use, there's a lot of good research that supports a lot of different kinds of treatments. So, for example, CBT, which is called cognitive behavioral therapy, which is one type of therapy we'll talk a little bit about later in this class. Motivational interviewing is MI, and family-based approaches where the entire family might be involved. Those have got pretty good research behind them showing that, for substance use disorder alone, they're fairly effective. There's not as much research on 12-step programs, for example, Alcoholics Anonymous or Narcotics Anonymous with adolescents, but the research that is there says that there are some positive effects, so that may be useful as well. There's far less research on treatment of dual diagnosis, and that's just true everywhere because, as you remember from the previous objective, not that many people are actually being treated for both things at the same time. The research that's out there says that the treatment effects depend on the type and severity of the other psychological disorder. And one problem in which it is very difficult to treat is called conduct disorder, and conduct disorder tends to develop into something you may be familiar with called antisocial personality disorder in adults, but in children it's called conduct disorder. And with conduct disorder, it's hard to get engagement in the treatment. The kid will just sort of tend to tune out of everything, and the treatment is not great with that. On the other hand, if depression or anxiety is the other mental illness beyond substance use, then a lot of times the treatment is more effective. So it depends a lot on what that other disorder is. As I mentioned before, the treatments and the programs are unavailable. They're underused. We are just not seeing treatment for dual diagnosis. But, there are some promising aspects. It looks like maybe there might be some treatments that could be extended to the dual diagnosis situation. But as of now, we're not doing a great job in treating adolescents. We're also, surprise, surprise, not doing a great job in treating adults with dual diagnosis. There's sort of this problem with treatment programs in which they don't really want a lot of times people with severe mental illness, and that's because they're much harder to treat because they don't have the facility to be able to treat them, and it's hard to integrate a person with severe mental illness into, for example, an AA group, an Alcoholics Anonymous group, or Narcotics Anonymous group, because the mental illness may cause other disruptions. There's an extremely high risk of dropout, people with two disorders. And so you have to really create a program in which you're minimizing that risk of dropout. And so we'll talk about that in some of the next slides. Therefore, we get this kind of revolving door of treatment where the person goes into treatment, leaves treatment, comes back, goes into treatment, leaves treatment, comes back. I mean, it's just a constant revolving door. And because of that, treatment costs are estimated to be about 60% higher in people with just mental illness plus substance use versus mental illness alone. So it's really a problem. So there are different kinds of treatment, and I'm going to talk a little bit more about what we call integrated treatment. But first, let's talk about some of the more common types of treatment, which is parallel treatment. And that is the idea that your treatment for the substance use disorder is taking place in one situation, and then you have the treatment for the other psychiatric disorder, for example, depression or whatever, that is taking place in another situation. So these treatments are taking place at the same time, but you're only treating one in one place and another in another place. They're going along parallel. Never do the twains really meet, and that's not particularly effective. Sequential treatment, which is treatment for one, so you do one disorder start to finish. You sort of treat for the substance use disorder, let's say, and once the person has been abstinent for some time, then you treat for the other disorder, or you do the opposite, treat for the major mental disorder at one on the first time, and then the substance use disorder. That's sequential. The integrated treatment model is concurrent or simultaneous treatment of two disorders at the same time in a program that is tailored to treating mental disorders at the same time as the substance use disorder. So integrated treatment is both together at the same time. And unfortunately, that's fairly rare. Well, we know a few things about dual diagnosis patients or clients. Adding dual diagnosis groups to regular treatment, if you just take treatment, for example, for AA, let's say for alcoholism or alcohol use, there you add a person with a psychiatric condition, for example, like bipolar disorder to that group, that doesn't tend to be very effective. Intensive inpatient integrated treatment is also not effective. And they say, well, why not? I thought you just told me integrated treatment was effective. Well, you're treating both disorders at the same time in a very intensive treatment program. We have a huge dropout rate. And that makes sense, right? Because it's a challenge enough to deal with one disorder, but the other disorder at the same time, there is being required quite a bit of the client. And so the dropout rate is huge. People leave treatment. And again, this is adults, so they can leave treatment, so that's a big problem. So integrated treatment can be effective, and the research shows that it can be effective, but you've got to probably use less intensive programs. So the less intensive programs, that are not, inpatient programs, for example, the ones that are just keeping you there and you're living in this place during the program, but instead outpatient programs where the person comes in and then is able to leave and go home. Treatment programs that span over a longer span of time, but again, less intensive, that tends to increase the effectiveness because people just stick with the program more. There's just less dropout. Another problem is focusing on abstinence. The focus on you've just got to stop the substance and you've got to go off of it and you can never have any again. That concept actually doesn't do well because people just drop out of the programs. So if it is an abstinence-based program, many people will not even join the program, and many people who start it will not be able to continue. Instead, what's done is what's called harm reduction, and harm reduction is finding a way to continue using in a moderate way, but reduce the harms that come from using. So an example of harm reduction would be, not driving while drunk, right? So being able to use alcohol, but not driving while using alcohol, that's going to reduce the type of harm that can come to you. There are many, many harm reduction programs with the opioids that are medically assisted, for example, like methadone treatment. That's going to give the person the feeling of satisfaction of having the opioid, but also does not cause a high that could get them into trouble or cause greater harm. You've got to engage people. You've got to get people engaged. You got to keep them in treatment. You have to offer safe, supportive, sober living environments. Houselessness is not a good way to go through treatment. Not surprising that you'll get a lot of dropouts. So where do we go from here? We've got to increase policy, working toward integrated treatments, ones that are not as intense. I mean, we would usually think more intense is better, but remember, the dropout is a problem. Part of the problem is getting people trained, getting a workforce that is able to do integrated treatment, because a lot of people who are trained in substance use are not also trained in major mental illness of all kinds. So we need to make sure that people are trained in both things to be able to run these integrated programs. So that's all I have on today's objective. I want to cap the module with just talking about some major take-home points. One is comorbidity or dual diagnosis is very, very common with substance use disorder co-occurring with another psychiatric condition. The causal relationships are really complicated. It may be that the mental illness is causing the substance use is causing the mental illness, or a third thing could be causing both things. Treatment and other outcomes tend to be worse in dual diagnosis. It tends to be more severe, and the more severe one of those diagnoses becomes, the more severe the other tends to become. So it's harder to treat, it's more expensive to treat, but again, it's super, super common. Dual diagnosis programs that offer treatment are often not effective. And so we really need to have integrated programs for increased effectiveness of dual diagnosis. And remember, those less intense programs are better. More research is certainly needed in this area to try to nail down what are the most effective programs. Okay, hope you guys enjoyed Objective 3, and I'll be seeing you.